leads us on to our next talk from Henry Fisher. Henry, did you work for Volteface before?
Yes.
Yeah, you did work for Volteface before. Volteface were pressure group, lobbyist groups that were involved in the recent media campaign to change the law of cannabis, which was quite successful.
Yeah, right.
Yeah. And he's going to talk to us now about his views on that, his experience on that, and how this parallels or not, as the case may be, with what's happening with psilocybin community. Thank you.
Yeah, thank you for inviting me. It's actually quite nice to be here talking about psilocybin, because actually my very first job working in drugs policy and sort of my entry into this whole world was actually working at the Beckley Foundation, which focuses not just on cannabis but obviously psychedelics as well. And then from there I've gone on a kind of fairly circuitous route. I was part of the kind of founding team at Volteface, who, as James mentioned, they are a drug policy think tank that focuses in particular on cannabis regulation. And then from that have gone on and focused on cannabis mainly. So it's nice to come back here and actually be contrasting and comparing cannabis to psilocybin and what lessons we can learn from cannabis when thinking about actually the medical use of psilocybin. So just as a quick overview of what I'm going to talk about. So I'll quickly run through what's gone on in kind of recent years and months in particular when it comes to the UK's kind of path to medical cannabis regulation, and then a little bit about the actual background on the kind of conditions and drivers for reform, and what actually leads to medical cannabis regulation around the globe, and what's increasing its momentum, and then look at cannabis versus psilocybin, and perhaps interrogate some of the differences that might mean that the drivers behind medical cannabis regulation may not apply to psilocybin, but why also that might not be a bad thing. So first, medical cannabis reform, the UK's path to medical cannabis reform. How did we get here, and how have the regulations come about? So there's a longer story to this than just the last 5 years, but really in the last 5 years is where things started to happen dramatically. And in fact, I spoke to a friend of mine who's on the ACMD when I first started working at Volteface in 2016, and his prediction was that the UK was still between 10 and 20 years away from legalising medical cannabis in any form besides Sativex. I'll talk about Sativex later in particular, but more generally, still over 10 years away. And just over 2 years later, we now have at least a system of medical cannabis regulation in the UK. So things have changed very, very dramatically and very quickly. The start to that kind of dramatic change in particular is in 2014, when a group called the United Patients Alliance was founded. So prior to this, cannabis activism groups tended to focus more on non-medical regulation, and at least in the UK, and there was little scope for looking at medical specifically. It was kind of treated as a side note and a footnote, and the two issues got very wrapped together. So the very first step on that was the formation of a specific advocacy group for patients. Beyond then, so 2015, it wasn't an issue in the 2015 election at all. It was part of the Liberal Democrats' manifesto legalising medical cannabis. And interestingly, there was another party that ran not just on medical cannabis legalisation as a manifesto promise, but also non-medical legalisation, and that's a party called Sister, Cannabis is Safer Than Alcohol. They didn't win any seats, they didn't get very far, but what they did is they brought together two people, Steve Moore and Paul Birch, who, after that fairly calamitous election campaign for them, it turns out trying to run a party full of stoners is not the easiest, not the easiest campaign to run. But they then formed Volteface, thinking something more intellectual needed to be done to actually focus on cannabis. And the aim of Volteface from the very start was to bring a coalition together of people who believed in medical and non-medical cannabis reform, and just expand that coalition and get more people on side, increase the saliency of the debate, with the hope of actually kind of building something useful, bringing it out of the sidelines. And so that's what Volteface duly began to do. Alongside that, there was the formation of another campaign group called End Our Pain. Their specific focus was actually bringing MPs on board to support medical cannabis reform. 2017, that momentum continued to grow. There was an increase in interest from the media, and this was in a kind of wider context of it gaining more interest globally, but I'll touch on that in a moment. One of the, a significant factor was the MS Society in 2017 publishing their own, or changing their own stance. They did their own review of the evidence and came out in support of medical cannabis regulation, as did the Royal College of Nursing. And this all led to the kind of building of increasing coalition of support. Alongside that, there was a conference in 2018 called Cannabis Europa, and that was the first time that the actual kind of the economic potential of cannabis from a kind of global perspective was brought to the UK, and it brought both kind of politicians from all over the world, but also medical cannabis companies from all over the world to London to actually show that this industry was growing and was legitimate, and needed to be listened to. Then something very significant happened in 2018, and that is the two stories of Billy Caldwell and Alfie Dingley. So if just as a quick recap for that, these are both two small boys who have rare forms of childhood epilepsy, both of which weren't treatable with the traditional or common medicines. But for both of them, what was useful was medical cannabis. They each have their own stories that go along with it, but what both of them created, or what the stories around them both created, was a sense of injustice around the UK's medical cannabis laws. And this came to the head in May 2018, and this is when things started to change dramatically. Alfie Dingley's story came to head in March 2018, but Billy's came to the papers in May. What had actually happened was there was a GP in Northern Ireland who had been prescribing Billy medical cannabis on the NHS somehow for well over a year. And the Home Office got wind of this at the start of 2018, wrote to the GP and said, "You can't do that, that's illegal." At which point the GP stopped, and Billy started having seizures again. What Billy's mother, Charlotte Caldwell, then chose to do, with the support of actually a Canadian medical cannabis company, was fly out to Canada to obtain medical cannabis, and then fly back to the UK to challenge the authorities on whether they would take away Billy's medicine. And she pre-warned customs when she flew back on the 11th of June that she had this banned medicine and what were they going to do about it. And customs officials confiscated it from her. There was then a kind of interesting back and forth for about a week where the Home Office said, we support customs, that's definitely illegal. And the media furore around it grew. Billy was put in hospital, he started having seizures again. And in fact, the Home Secretary, Sajid Javid, reversed the Home Office decision and declared that Billy's medicine could be returned to him, and that he would start a rapid process of reviewing the medical cannabis laws in the UK. And if we just take a step back for a moment. So this started to happen in June last year, and by 5 months later, 1st of November, medical cannabis legislation had been enacted and was in place. So that's 5 months under a pretty socially conservative government that is fairly distracted by Brexit. That's a huge change in a very short amount of time, and it's testament to that campaign that had been built beforehand, that they were able to put so much pressure on the Home Secretary that he felt he needed to act very swiftly. I won't talk through all the specifics of how it happened, but basically there was a review process. It went back and forth between the Chief Medical Officer, the Advisory Council of the Misuse of Drugs, and the MHRA. They all fed into the new legislation, and by the 1st of November, we had at least legislation for medical cannabis. What does that now look like? So the current UK policy there's now a group of medicines that have been defined as cannabis-based medicinal products. What that is if something fulfills these 3 limbs, which is first, it contains cannabis or a controlled cannabinoid. Secondly, it's produced for medical use in humans. And thirdly, it's a medicinal product. Then it's classed as a cannabis medicinal product, and it can be prescribed under specials medicines legislation. That's still very restrictive, and it means that there's still very few people that get prescribed it currently. It will all be dependent on how things change following kind of subsequent NICE guidelines, but that's where we are at the moment. At least patients can be prescribed medical cannabis, which is not the case, or wasn't the case, over 3 months ago. So what drives medical cannabis reform? And this is both the case in the UK, but also kind of looking more globally. And these drivers differ from country to country, depending on what the laws of the country are and what the kind of local situation is. But I'll just kind of work through each one briefly. So legal challenges. This is the idea of when there's an individual patient who needs cannabis for some very good reason, for example, Billy Caldwell or some other candidate, and they then challenge the courts to say they need cannabis. It's either a human rights violation that they're not being allowed their medicine, or whatever it might be. That often gets a foot in the door, because after the courts decide that one patient can have their medicine, the next step is, well, why can't other patients? And it opens the door to wider reform. Alongside that, a driver for at least the last 40 years has been this gradual building of medical research. And there was really very little firm medical research beyond kind of 20, 30 years ago in terms of the medical use of cannabis, and that has gradually been building and building. It's still got a long way to go, but that has helped drive reform globally. Public opinion has also shifted. It's essential to have public opinion. Well, usually it's essential to have public opinion on side when it comes to medical cannabis reform. In particular, in states and in places where you can have referenda on the subject. So that's been a key driver in US states. It wasn't really, it's not so much of an option in places like the UK where referendums aren't usually held on these subjects. But having that level of support is still useful. Political support is obviously key. That is something that in the UK, up until very recently, there was very little. So neither the Conservative or the Labour Party supported medical cannabis reform until they were put under pressure by the media. Activism and advocacy, they're two clearly very different things. So one is grassroots activism, so groups calling for change and knowing what they're calling for when it comes to change and why they're calling for it. And advocacy is holding up cases, in particular when it comes to medical cannabis reform, cases of patients that are being denied medicine and kind of holding politicians' feet to the fire. Support of the medical professional. This kind of goes hand in hand with medical research, but they are different because the medical research can be there, but doctors maybe may not be aware of it, or they may not be educated in why it's important or useful. And that's something which certainly when it comes to psilocybin, I think we're not there yet. Most doctors have no idea that actually psilocybin could be a useful drug. And then the last driver is markets and investment. And for cannabis, this has been a huge driver. In the early years, so kind of 90s and early 2000s, this wasn't really the case. But in recent years, in the 2010s, the creation of a global market has put medical cannabis reform on rocket boosters, because now there are well-funded lobbying campaigns, but also countries can see why it might be useful for their economy to actually reform their medical cannabis laws. There are still challenges facing medical cannabis regulation at the moment, and I think one of the most interesting things about cannabis and why it still faces challenges is the fact that it's quite a complex drug. It's not a single API, so even in the most simple formulations, generally you have two compounds, THC and CBD. That's already more complicated than most drugs. In many formulations, it may even be in a kind of flower form. It's incredibly complicated. And this creates complications when it comes to how you actually regulate that in a strict medical cannabis, a strict medical regulatory setting. How does such a complicated drug fit into it, especially when everyone can get their hands on it already illegally? I think I've said all the rest of them. So where does that leave cannabis versus psilocybin? So first I'll say a bit about the similarities. So obviously the first similarity is they're both Schedule 1 drugs. That's obviously exempting the fact that medical cannabis has just been rescheduled. But cannabis itself still remains a Schedule 1 drug. It's only cannabis-based medicinal products that are Schedule 2. So in Schedule 1, that means that it's assumed that they have no therapeutic use and high potential for abuse. And the definition of abuse that the Home Office takes here is not that it can lead to addiction, but just simply that it can be used recreationally. That's what they class as abuse. So it can be used recreationally, so it can be abused. They're obviously both traditionally obtained from nature. There's kind of complications there as well, because if we're talking about psilocybin itself, the compound, we're not talking about magic mushrooms, we're talking about this one compound. Two key patient groups where it could be very useful: end-of-life patients, where there's generally a lot of what's the word? Existential despair. That's what I've got right now. No. Compassionate use, that's the one. Compassionate consideration for end-of-life patients. Similarly with veterans, there's a huge amount of support, especially in countries like the US. Obviously, both drugs have significant non-medical use worldwide. They're both easily obtained illegally and cultivated at home, which comes with its own challenges from a kind of regulatory perspective. If people can just get them from some other means, then there is a sense of urgency needed in how we actually regulate it so that people can access a well-regulated product, and that can be used to the benefit of actually trying to push for reform. And of course, with both, there is a growing body of evidence supporting medical efficacy. However, there are differences, and just touching on that last one, the growing body of evidence, there is still much more evidence that exists in terms of peer-reviewed journals and what have you, peer-reviewed papers for cannabis even, than there is for psilocybin. Now, the evidence in those few papers that exist for psilocybin may be more conclusive than it is for a lot of the research done on cannabis, but the case still remains that that body of evidence is not huge yet. There's some other huge differences, and this, I think, the one that stands out to me the most is the multiple APIs versus single API, API being active pharmaceutical ingredient kind of difference here. So with cannabis, the reason why it tends to break regulatory norms and why after reform campaigns kind of are launched, there always needs to be a new host of regulations brought in, is because it is such a complicated medical product, and why there is a huge market. You know, every single company can make a different medical product from cannabis that contains a whole bunch of different APIs. Whereas with psilocybin, we're generally just talking about psilocybin. It's one thing. And in that respect, it makes it much easier to actually deal with, because that's what our medical regulatory system is set up to actually to regulate single APIs and drugs that are made from them. There's some other key differences as well. So the way cannabis is used versus psilocybin in a medical setting. Typically, cannabis is used, especially in contexts like chronic pain or spasticity with MS, frequent dosage, long-term use, and in an unsupervised setting. People take it home and they use it in whatever way they want to, and there's a whole host of ways that people then use that. When we're talking about psilocybin, it's generally assisted psychotherapy in a controlled setting, short duration, with just a few administrations of the drug, or maybe even just one. And so that means it's actually in a much more controlled environment and much more easy to regulate when we get to that point. A few other kind of key differences. One is the market in particular. So with cannabis, like I said, there is a huge and growing market in cannabis, and that will only grow as more countries reform their laws and realise that a significant part of their population want to use cannabis medically for some reason or another. With psilocybin, that's not yet been established. Most countries don't really realise that. And also, where does the economic potential come from with psilocybin? Obviously, I think Compass are probably going to say something about this later, but it's not immediately obvious where there is space for a whole host of companies to be driving for reform. Where are all the different formulations of psilocybin? And also what can be kind of capitalized on. So the drug or the compound exists. It's very hard to actually patent that one compound and then capitalize on it economically. Obviously, Compass have gone about it by filing a patent specifically on how to synthesize psilocybin chemically. That's one way around it. There may be patents that exist for it being used in a specific way, but that economic drive isn't there yet with psilocybin, and that's what drives medical cannabis reform around the world currently. One other difference that I really want to touch on is where does the kind of media furore come from? Who are you going to hold up to the Daily Mail and say, this is the poor child who is ill, who only psilocybin will cure, that needs to be shown to the Home Office, and this is why you need to change your laws because this child will die otherwise. And as of yet, there's not really a kind of case to be made for psilocybin there. Obviously, it's very useful for a lot of adults with depression or a whole host of other mental health conditions, but it's harder to construct a narrative around that will make politicians sit up and listen. So what is holding back medical psilocybin regulation? I kind of just touched on some of those points already, but the key one for me, most of all, is economics. How do you commercialize it? Where is the interest for pharma companies? Why would they bother pursuing it? And if they're not going to pursue it, who is going to do it instead? Obviously, there's cases like MAPS and other organizations, but it's not immediately obvious where the economic driver is going to come from. Research is obviously still way behind. That needs to be built up so that medical regulators have something to actually kind of get their teeth into if we want to regulate medical cannabis in some way. And of course, there's kind of structural challenges. How will it be used and supplied? And how do we educate medical professionals about how to use it? There's obviously common misconceptions about psilocybin. Invariably, when a study is reported in the news, people talk about magic mushrooms as being the cure to everything rather than psilocybin itself, which confuses things further. And of course, that's the kind of historic prejudice and prohibition then kind of comes in and can influence it. But I think it's slightly less relevant in a medical context, because if we're talking about regulating a specific substance, that can be done. It was done with cannabis, and with one instance of cannabis, leaving the rest of it behind, when GW Pharma regulated Sativex specifically. So medical cannabis reform and whether this path fits psilocybin, as I've mentioned, the primary barriers to medical cannabis reform relate to the complexity of the product, the fact that there's widespread use of self-medicating, and it's got a rapidly expanding commercial potential. And those are very different to the drivers that are kind of underpinning the reasons for reforming medical psilocybin regulation. So which path should we be looking to instead? And there's kind of a few examples. And one in particular that I think has the kind of, that we should be looking to instead of looking at kind of broader medical cannabis regulation is what's happening at Warneford Hospital. I imagine a good number of you know what happens at Warneford Hospital, and that is that you can go to Warneford Hospital, well, you can get, what's the word? Can't remember. But you can go to Warneford Hospital and be administered ketamine for treatment-resistant depression. In a very similar setting, or in a very similar analogy to how medical psilocybin might be used in a clinical setting. And so that's the actual kind of the model that we should be looking to when we're talking about medical use of psilocybin, and actually using ketamine as an analogy to say, well, it's been done for this drug, which is also contentious, why can it not be done for this other drug? The other, I think, key example that we should look for is Sativex. So I have deliberately not mentioned Sativex when I've been talking about general medical cannabis reform, but Sativex is a drug that GW Pharma produced from cannabis, and it was actually regulated years and years ago in a whole host of countries where medical cannabis laws have not been brought into place yet. And they did so by actually working through extensive clinical trials and working with the system rather than trying to work against it and break it, essentially. And because medical psilocybin is a much simpler compound when it comes to how we treat it with regulations, in terms of it being a single API where you can just do, where you can build standard clinical trials, that is the route that we should be looking to actually emulate with medical psilocybin rather than looking at broader medical cannabis reform. So, a very brief roadmap. I've kind of mentioned all these already, but point one is clinical trials. We should be looking to conduct many more clinical trials. Point two is there needs to be investment and institutional support to allow those trials to take place. Now, where that comes from is, I'm not going to offer a guess, but it needs to be found from somewhere, and that will be the stage to unlocking an increasing kind of body of research. And then finally, when it comes to kind of it getting closer to regulation, there will need to be a campaign for doctor education so that they can actually understand what it is that medical psilocybin can do and why it is such a potentially useful medicine. Thank you.